Hello, Robert Bastian here. This is part two of a discussion of use of suction drains as a treatment tool in head and neck surgery. I did a brief introduction as part one just to give the overall rationale, and now I want to get into a little bit of the nuts and bolts of the idea, but there will be some review in this. And again, I'm not talking about suction drains used to post-surgically to just evacuate under flaps, but I'm talking about it as a treatment tool for fistula. And the primary circumstance would be after cancer resection, especially total laryngectomy. So here we go. So I explained in an earlier video, and again, this may be just of historical interest because I am not any longer in touch with how people are managing fistulas today. But in my training and for 10, 20 years after that, the traditional management of fistulas was that you would take out the suction drain and you would put a Penrose drain overlying what's called the trifurcation. This is a total laryngectomy, the trifurcation, which is the area most likely to break down. Now, this is a utility flap here, but normally the incision line is going to be much lower, and so this opening would be right in the hole in the flap. Then in my residency especially, those patients had to stay in hospital because we did all kinds of treatments. We changed dressings at least twice a day. Patients were sometimes in hospital 6 weeks if they'd had a lot of radiation and chemotherapy. And it was these dressings twice a day. There was a lot of odor, especially if there was some necrosis of the underlying tissue here. And so it was a big deal. It was a big problem. And fistula formed in, somewhere, I think different reports, I haven't looked this up for a long time, but I think fistulas after total laryngectomy is somewhere between 1 in 6 cases and 1 in 12 cases. So it's not an uncommon complication after a total laryngectomy. It doesn't make any difference to final outcome cancerologically or to voice or to swallowing, but it greatly delays the postoperative course. Well, this, in my opinion, is a miserable way to manage fistulas. And why find a new way? Because that management, that old management, is unpleasant and dangerous. All those dressings, the odor, risk of carotid blow if the saliva and secretions were going across a carotid, very labor intensive, and it's expensive to the system. All those added weeks of hospital stay, the antibiotics and so forth were unpleasant, labor intensive, and expensive. And just quickly to review the genesis of the idea, 1983, I was in Erlangen, Germany, and I saw an endoscopic laser resection of a large laryngopharynx cancer. I think it was a post-radiated case, and it was by Dr. Wolfgang Steiner, the very famous advocate of large laser resections, which I later did a lot of. But I remember, having not really seen that kind of approach, thinking to myself, oh, it's interesting that he's going to have a huge defect in the mucosa, but there's no risk of fistula. Now, that's an obvious thought today, but back then it was kind of a new idea because pretty much, other than some tongue resections and vocal cord and so forth, we hadn't yet begun doing very large endoscopic laser resections. So I remember just that idea flitting through my mind. This procedure took many hours. I remember asking him, well, when do you stop? Because he was working for hours and hours taking out this very large cancer. And he said something like, when you feel this, you have your hand on the outside and when you feel the skin is warm. So I remember having the idea that, well, then there's a very thin layer of skin and yet we're not worried about a fistula or breakdown. So that led me to the following thought process. I thought to myself, okay, here's the incision right here, the red line, and these are the staples drawn across. Imagine that the larynx here is gone, and the area of greatest risk of breakdown is usually the trifurcation right here at the base of tongue. So now imagine that this red dot represents a fistula, and now we're going to see some saliva begin to leak out of the fistula, and it's going to come between the skin flap and the other tissues of the neck. And then it's going to become infected and everything, and it eventually leaks out through the incision line, sometimes right at the tracheostome, and sometimes farther laterally. And if there's been a neck dissection, it's a cause of great concern. And so people said, oh, we better put in fresh tissue and, free flaps and all of that kind of thing. Well, what was the aha? The aha, and again, this is so obvious as for people to say, you were sort of obtuse in your thinking up until this point, but that's the way it is. Things that become obvious to us are obvious, and they weren't obvious at one point. So I suddenly realized that the idea was the problem was the elevated skin flap, not the defect in the mucosa. You can go in through with a laser, make a huge mucosal defect, but as long as you haven't raised a flap. So that led me to start thinking, okay, how could I do open surgery but get that flap to stick down as though I hadn't done open surgery and I had done a laser? So I began thinking about that, and what I came up with was this better alternative, that we use the original suction drain placed at the time of surgery to manage any fistula that occurs. So this suction drain isn't going to go just here in what we used to call the gutter, but it's going to work its way right up to the point of greatest risk of breakdown, so that's where the drain is going to go. So there's the fistula, now it's blue, and now you see the line of the drain is coming across the carotid. Even with a radical neck dissection, you just come right across, and no flap. You just come right across the carotid, and you direct your drain right to the point of the fistula. So what happens is there's an early warning system, so you come around to see the patient, and I was usually the first one to notice when we'd have a fistula. I'd say, oh, do you see the little white cell clumps? So instead of serosanguinous, blood and serum, you'd see these little white specks in the drain, and I'd say, aha, we're getting a fistula here. And sure enough, within a day or so, it would become obvious that we had a fistula. So this drain is intentionally placed as what we call the control drain or the monitoring drain, and it's ready to stay there as the fistula drain if a fistula happens. And so you see these white cell clumps or bubbles. So if that happens, you don't remove the drain and medialize, you just keep sucking on that drain until the pus and saliva, the bubbles and the white cell clumps, begin to clear up. And now you see segments of serous drainage and then a few white cell clumps, and now a segment of serous drainage and a white cell clump. And as you see that begin to happen, it used to be all cloudy and nasty, then you remove the drain, you shorten it. And I would do this right at the bedside. I would use the same drain, even though it's filthy, it's been, sucking fistula fluid. I would just use the very same drain. I would take it out, shorten it, and put it right back into the same site. Now, what would happen is the skin would turn red for a couple of days, and then it would go back to more white cell clumps for a day or two, and then it would again go serosanguinous, and then you would take it out and shorten it a bit more. You'd get a little redness of the drain, of the skin flap, and some increased white cell clumps, and then after a day or two it would become more serous, and you'd do the same thing. So it's led to my regular management of fistulas using the suction drain as a treatment for the fistula. Pardon me. And here's the article from 1995 with my resident at the time, Albert Park, and the two of us put this article together. And I remember, by the way, presenting this at either the Laryngologic or at the AAO, I can't remember which. And I went through a very detailed, I had 8 minutes or 10 minutes, and so I timed every word, and I had great visuals and everything. And when I finished, I remember Had an ex-surgeon from a large VA hospital stood up and said, "I don't understand this." He said, you just medialize, you just put a Penrose drain in there and put a dressing on. And so completely went over his head what the whole concept was here. So that's why I'm being a little detailed in talking to you about this here, maybe more than I think some of you have got the idea and you can click off of this. But so to repeat, reiteration is good. The suction drain strategy is put whatever drains you need to put in, like this one on the left side, just for evacuating under the flap. So if you need 2 drains or 3 drains, that's fine. So here you see one under the flap in the gutter. Here's another one under the flap. But you always must have at least one control drain or monitoring drain. And so this is the area that's going to break down typically, if anything is, and that drain is sitting there ready. The minute there's a little bubble of saliva or a white cell clump, it's going to go into the drain, and you're going to, once it emerges here, you're going to see, and you're going to say, uh-oh, I think we're going to get a fistula here, and another day or two, and you're going to see that, yep, you do have a fistula. So you assume everyone will get a fistula and place that drain intraoperatively to control that maximum risk. Now, unless you have no worry at all, you try to leave the critical, the monitoring, the control drain in place for 6 days, because that's the median day of fistula occurrence. And I again call it the control drain. Why 6 days? Not just because of the median day, but because if you leave that in there for 6 days and you take it out, and a day or two later you were wrong and now you see you've got a fistula, it's usually pretty easy to fish that drain back in. If you take it out after 2 or 3 days, it's a little harder to get that drain to go back up to where it was. Now, again, you're going to see the white cell clumps or bubbles. I've tried to kind of illustrate that here. That should be yellow serous, and then you just keep sucking until the pus or saliva stop and become clear. Then you remove, shorten, and replace. So here's the original drain, and then maybe on post-op day 10 or 12, maybe this person got a fistula on day 6, and so she goes home with the drain in place. She doesn't stay in hospital. See her in the office maybe on day 9 or 10. She is in hospital just long enough to make sure that you're controlling the fistula. Pardon me. But, if you're controlling the fistula, you can send her home, and all she has to do is squeeze the grenade, and, once or twice a day. So here you see I've shortened the drain because presumably the drainage has cleared up some. Put it back in. Again, the flap will turn red a bit and more white cell clumps. Then after 2 or 3 days, you pull it out again. Why not pull it all the way out once the drainage becomes kind of clear? Well, because you may create an abscess right here. In other words, this has been a soiled tract, and that's why you have to back it out. So you remove, shorten, and replace, remove it again, and all of this takes minutes to do in the office, not in the hospital. So again, this person is in, I think our standard hospital stay after total laryngectomy is 5 or 6 days. And so you don't need to keep them in hospital. You can send them home with this system. And then imagine that this tubing is gone. And sometimes the very last part that I take out, I will just take a Caldra swab with peroxide for another couple of days. I have the patient do that. Now, again, you can do this in someone who's heavily radiated. You can do it in someone who has had a radical neck, not just a functional neck, where the carotid is exposed, because if you think about it, the body can fend off infection that is drained. So you don't have to worry about that carotid, or if you have movement, if there's egress of saliva and pus, you do not have to worry about the carotid. Here's someone who you can see is heavily radiated, chemotherapy. I wish I could find a photo that I have of a woman who had liver failure, diabetes, heavy radiation, and her neck turned kind of black, I remember. I mean, it looked really kind of impressive. There was no free flap, there was no pec flap, and I just kept sucking on her fistula, and after about 6 weeks, excuse me, all of which time she's home, other than maybe, I suppose she was probably in hospital 7 or 8 days just to monitor for a day or two, make sure she understood how to manage the drain, because there's a grenade at the end that she has to punch down, or family do. So I've done this kind of thing many, many times, and I never got into any trouble. So again, back to the beginning, what problem does this alternate management solve? All of them. It's not unpleasant or dangerous for the patient. There's no dressings, there's no odor, there's no risk of carotid blow as long as the drain is working. It has to be working. And one of the interesting things about managing fistulas these ways is I used to think that there would be, because the drainage was so profuse when we did that dressing and Penrose drain, I used to think that there should be a large output out of these drains. And sometimes there is for a day or two, but fistula drains are actually not that high of output. So patients are not having to, now once in a while there's a big breakdown and now you are sucking air. So a time or two I had to send someone home with a portable suction, and they would put the machine behind the sofa or behind the bedside table or something, because it's a little loud, those portable ones are, and I just say, who cares if we wear out a suction machine? And so people would just manage that at home. If it leaks air, that's because your tip of your drain is you put it too close to so you want to be a few centimeters from the point of breakdown. And so occasionally you have to pull it out and shorten it just because you're sucking air. But no worry, if you're sucking air and squealing, you just deal with that because you're controlling the whole situation by the suction. So it solves the unpleasantness, the dressings, odor, and carotid blow worry. It solves all the labor for doctors and nurses. That goes away. And it solves huge expense because remember, these patients go home. I've had people at home for 5 weeks before their fistula healed. Now, here are a few other ideas. You can leave the drain lateralized due to the active removal of saliva and pus. You don't have to say, oh, I better bring it out anteriorly because I don't want to cross the carotid. It doesn't matter. You reduce the need for flaps. Patients can go home after you confirm that the drain is doing its job before the fistula is healed. And the only thing is you must verify good control and that the patient knows what they're doing. The concept won't fail. The implementation can, however. So if you send someone home and they don't punch down the drain, or there's no monitoring, you can have a failure of the whole idea. It really didn't happen in my experience, but can happen. So is this idea safe? We did, again, this analysis where we looked at fistulas managed in both ways, and there was essentially no difference between the two groups. So there's the idea, and I think you'll like it, and it's highly debatable. Is it better to throw in a flap and take all of that added morbidity and extra stay in the hospital, possibility of flap failure? Is that better? And thinking that maybe you'll reduce the incidence of fistulas, or is it better to just use local tissue? I mean, voice works well, swallowing works well. You end up using this method with the same kind of result as if you had removed everything with a laser endoscopically. So just for your consideration, there it is, and thanks for listening.